go. Welcome everybody to Contemporary Issues class. Thank you for coming out today. Welcome to our first time visitors too. My name is Steve. I'm the leader of the class, and we are pleased today to have Rev Amy Stapleton and my wife Vicki Vasquez speaking about hospice today. They're both very experienced with that, and we thought it would be a good topic for us to learn about and ask questions. But before we do that, our usual announcements, Zoomers, please mute yourself in the lower left corner of your screen when you're not speaking, but we would love to have you ask questions or give comments too. And we are recording this for future playback on YouTube for those who are not able to be with us today. So that's your notice there. A couple of other announcements. Rev Amy has a gender class at the moment that is really good, and I'm going to come to explaining about gender issues today. That's on Tuesday nights, Amy, and people can just come and drop in. Great. And lots of other good classes going on at church here. If you want to look on our website under studies, that's where the classes are listed, so take a look at those too. And in this class next week, we have a speaker talking about Mormonism, what it is today. And we have a St. Andrew member who used to be a Mormon in Salt Lake City and moved here and became a Methodist. So it should be interesting. And then 2 weeks from now, we have the topic of medical aid in dying. And somebody from Littleton will be speaking that's been featured on the Frontline TV show. But an interesting topic also about doctor-assisted aid in dying. And then finally, 3 weeks from now, Douglas County School Superintendent is going to be here to talk about the election issue, tax increases that are proposed for the Douglas County School District. So that should be quite interesting too. Okay, with that, I want to introduce Amy and Vicki. But I want to share one quick thought before I do, and that was, I was reading yesterday an article in the New York Times about Jimmy Carter being in hospice. 99, maybe Amy's going to talk about it, 99 years old. He's been in hospice for 7 months and goes up and down, but he's not immediately in danger of passing. But he thought back in the spring when he went in, he thought he was 5 days away from passing. And he's just had an amazing life. And the funniest part of the article was that it said he and Rosalind live in a 2-bedroom ranch house in Plains they've had since 1961. And that the Secret Service men joke that their vehicles parked in front of the house are worth more than the house itself. The 2-bedroom ranch house. So, yes.
Yesterday on my phone that Jimmy Carter and Rosalind got in a car and took a tour through Plains the other day for the Peanut Festival.
For the Peanut Festival. Good for them. They were able to get out.
Wow. Yes. They got a car and were driven through.
Good for them. Yes, that'll be a. Sorry, go ahead, Linda. This week is his birthday, turns 99. He was hoping to make it this week to 99, it said. Okay, with that, I want to introduce my wife, Vicki, who is a hairdresser by training, but she also volunteers for, she's been a Stephen minister and a hospice volunteer, a non-medical hospice volunteer, support in other ways, but not administering medications. And Rev Amy is our pastor of care and justice here at St. Andrew. Before that, she was in Severna Park, Maryland, where you were a licensed clinical professional counselor and manager of the bereavement services there. So she says, I also offered school and community-based bereavement training and did presentations at state and regional gatherings also. And Amy, for those who are interested where people went to college, Columbia College in South Carolina, and she also went to Iliff School of Theology, Master of Divinity, and Loyola, where she got a Master of Science in Clinical Mental Health. So with that, thank you ladies for being here. I want to give this to you, and just please be sure that folks in the back can hear. Do you want to take questions during talking or, okay, so if you have questions, just raise your hand, questions or comments. And thank you. Please welcome Amy and Vicky.
When Vicki and I first talked about this opportunity today, we really are both committed to it being interactive, recognizing that everybody's experience of hospice may be different. So we hope that you will ask your questions, you will share your struggles, maybe even some fears as we move along. One of the things that I find it's really important to just kind of name up front is that there are a lot of myths about hospice. So I kind of want to talk about that some today. As a clinical professional counselor, I did manage, as Steve said, a bereavement program for a hospice that also served the community there. So we dealt with traumatic death, we dealt with different types of death, not just death in the hospice patients and families themselves. I also want to say that I believe in a good death, that I do think it's possible. There's a lot of things we can't control in life and that we can't control in death. But as an end-of-life doula, as a person of faith, as a pastor, as a clinician, I do think that it's possible for as much as we can to provide space for one another to transition in a loving, kind, supportive environment. And I think hospice has been a part of that for me, both personally and professionally. The other thing I guess I just want to just acknowledge from the get-go is it's important to have these conversations now while you're well, while you're able to make decisions for your well-being and your future care. I hear from a lot of people that, oh, I don't want to talk about that. That seems too far down the road, or my kids don't want to hear it. They're kind of in denial. You have more choices now while you're able to make the decisions for yourself in conversation with your family than you will be able to make in a time of crisis. I've worked both as a hospital chaplain and been in a medical environment that way and as part of a hospice. And I want to say, and this is no slight to the medical community, but you actually have less choices in the hospital. So have the conversations you need to have now. We have resources to do that here at St. Andrew, including 5 Wishes. We're going to be doing a lot, Rev Barb and I, in the coming months on how do you have a good death? What are the death boxes that you need to kind of check off? Like, where are your important papers? How do you have these conversations now that really prepare not just you for a good transition, but the people around you who love you?
My experience, well, let me tell you where I started. I went to Stevens Ministries training when I was in Kansas City, and all of the sticking in my mouth, and all of the experiences that I had through my Stevens Ministry training ended up being with every one of the situations that you would find yourself in with the Stevens Ministry, except for a hospice situation where you're at the bedside of someone who's actively passing away. And so when I completed my training, that was the only thing that I had not really experienced. And then within 3 months of finishing my training, my father went into hospice care. And so he was my first experience with hospice care. And he had been in the hospital. We didn't really bring hospice in until the very end, but we had a wonderful doctor who was right in there with hospice care and recommended hospice care to my family. And so that was my first experience with it. But he just said, you know, let's just take everything off and just let him go, you know. And that was my first experience of seeing how peaceful and calm it can be for a person without all the tubes and the medical technicians running around and doing all of that. So anyway, that was my after experiencing that, that was the driving point for me to want to work with hospice if I possibly could. So then when we moved out here, I applied to go to work for Denver Hospice as volunteer, non-medical volunteer. And so what I do is I get a care receiver, a patient, and I spend usually 1 to 2 hours a week with them, either in respite care, which means just giving the family member a break and they can get away, or it just means going in and spending time with that person. And I've done everything from giving them haircuts, which is something that I do often. I'm also on their list to call when someone needs a haircut. So that is, for me, since that's my profession, that is a real gift for me to be able to give to someone that is in their final days, because feeling like you look good when you feel so bad is such an uplift, and it's such an uplift for me to be able to do that for them, you know. So anyway, and then the other thing I do is just go in and spend a couple of hours with them. I've done their nails, I've read to them, I've brushed their hair, I've just sat and visited with them, talked about the past, and sometimes they don't even want to talk, sometimes they're asleep and I just sit with them and usually pray, you know. And so anyway, it's like Amy said, it is a beautiful way to die. You know, it really is. It's not always a peaceful way to die, but it's a beautiful way to die because there's not a lot of medical action going on around you, you know. So you want to fill them in on?
Yeah, just say a little more about the Stevens program.
Sure. Well, we have it here, but we've changed the name to Compassionate Congregational Care. And when I went through it, it was about a 9-month class, and we were commissioned. And then when you have finished your training, typically you're carefully paired with a care receiver that makes it known to the church or whoever's in charge of the program that you are in need of someone to walk along life's whatever it is you're going through, you know. I've been with people that have children that are in drug rehab, or and I've gone to meetings with them, you know, and just been with them. It's been several divorce situations that I was involved in, their own illness a lot of times, or just having a rough time with their psychological psyche, you know, just being with people. So it is a wonderful program to get involved in, you know. So, and the thing that has happened with me is I've found that when they are prayerfully selecting a caregiver to a care receiver, you always walk away. I have always walked away going, wow, God is so good. I mean, this is a person that has not only been there for me to help, but has helped me immensely, you know. So it's an amazing program to get involved in.
You'll hear a little more about that. In October, we're going to have a care fair here at St. Andrew and kind of reintroduce the congregation to all the ways to be a part of care, to access care. And you'll have the opportunity to sign up if you're interested in participating in that sort of ministry. I want to talk a little bit about the history of hospice and the distinction between hospice and palliative care. So hospice started about 105 years ago with Dame Cicely Saunders in actually England. And she really had this belief, she was a social worker, a nurse as well. She really had this belief that care doesn't just happen at the end of life. And death is more than just what happens to us physically. So her whole philosophy, which has now become a movement around the world, is that when we die, when we transition, all parts of us are involved, right? Our social part, our mental, our physical, our spiritual aspects of who we are all transitioning. And so her real philosophy was to attend to those parts of ourselves. So one distinction I would offer around hospice is that it involves a team. So you're not just talking about a doctor that's facilitating your medical care. You're talking about a chaplain, a social worker, a CNA that maybe comes in to help with bathing, a nurse that can administer medicine. So when you access hospice, you get a whole team of people. The thing that I really respect most about Cicely Saunders is that she really believed that people with a terminal diagnosis did not have to die in a sterile environment. Both of my parents have died on hospice, one in the hospital because we couldn't move her at that point. My dad died much more suddenly, but I think that the idea is that when we die, that we all want to feel loved and supported. In the hospital, think about it, physicians, nurses, they're trained to save lives. Sometimes they don't do as well at attending to the end of life because they're busy trying to save lives. So hospice gives us the opportunity to attend to all parts of ourselves. It's a little different than palliative care. Palliative care is something that I think has emerged within the last 15 to 20 years. Palliative care means simply this, that you manage your symptoms of a chronic condition. Palliative care is not financially supported by Medicare or Medicaid. It's something that is often negotiated through private insurances. Hospice, however, is a Medicare benefit and a Medicaid benefit. That means everyone has access at the end of life to hospice care. Palliative care is also, you can move towards treatments that remain curative for your condition. Hospice care is that you can still manage pain, you can still have access to comfort care, but you are no longer receiving curative treatments. Hospice comes with a terminal diagnosis. You have to be clinically certified to receive hospice care, not by just one physician, but by two physicians. That often includes your primary care doctor and a hospice doctor. So you can't just suddenly say, oh, I feel ready for hospice. You may feel that bad, but that doesn't mean you're certified ready for hospice. A lot of times people will say to me, well, how do I know when I'm ready? Or how do I know when my loved one is ready? That's not on you to decide. A medical team will come assess your condition and determine that with you. You don't have to know that for yourself. So hospice is essentially a 6-month or less approval status for someone with a terminal condition. Now, Linda and I were just talking about Jimmy Carter. One of the myths of hospice is that people think, well, that means I'm going to die in 6 months. That is not true. Hospice is something that you have to be recertified for every 6 months. I've known people to live for 7 and 8 years on hospice because hospice, and evidenced in the life of Jimmy Carter, is actually something that extends the quality of your life. And so when your pain is managed, when you have access to attending to these different parts of yourself, you tend to live longer. So they've done a lot of study, and the quality and quantity of someone's life is extended on hospice. As someone who worked with the hospice, I have to say, people wait too long to access the benefits of hospice. If you're in a critical condition or your loved one is, and you sometimes basically get certified and you hear these stories of someone dying 24 to 47 or 48 hours later, I have to say that's really too late to access and receive those benefits. Much better if you receive a terminal diagnosis to know, to anticipate, this is what I want for the end of life. So I want to kind of pause there and see if anybody has questions. Jim?
I'm confused though. You said that the patient doesn't decide that the that the hospice team decide when they're ready for hospice?
Well,
Maybe that's,
yes, it's in partnership with the family, with the patient.
but who initiates?
It could be both and. Often I find in my personal experience, somewhat pastorally and professionally as well, doctors are sometimes hesitant, unless you're working with a gerontologist, sometimes there's a hesitation to have the conversations of when someone is hospice eligible. Because largely, physicians are trained to save lives. They offer one class in medical school on death and dying. I've talked to those classes and doctors are panicked, right? Because they're like, how do I even say to a patient, you're dying? They're not equipped or trained to do this. Hospice palliative care doctors have a different training. So when someone is making that decision, it's in consultation with your physicians, but it can also be, and I think Vicki and I have this experience, you're advocating for your loved one and saying, you know what? This might mean we sign a DNR, a do not resuscitate, because this isn't going to get better. Or, you know what? It's time. We need a different level and type of care right now. So it can be initiated by the family or even by the person themselves. But you do have to have two physicians to certify someone as hospice eligible. Now, sometimes people will say to me, yeah.
Is it pretty much standard? I know your father is 94 and in hospice. He had a horrible hospitalization issue that really at that time really killed him. We medicated him from 94 when he was 24. And so along with it, no hospitals. Is that a standardization? Is that a standard practice from hospice? Like if you're in the hospice, then that means they don't go to the hospital, they keep them, because it's more about comfort care, is that,
That's a good question. You can go to the hospital on hospice, and hospice can be accessed in several different places. You can have many hospitals have a hospice unit, designated unit inside of the hospital. Like in the case of my mom, she was so unstable, we couldn't move her home or we couldn't move her to a hospice house. So she received care in the hospital for hospice. Hospice can occur in your home if there's a team of people to support you, but it can occur in the home with family support. It can also occur at a hospice house. Not all hospices have a physical location, but some do, where they can actually transport you to a hospice house to help you transition. Specifically to your question though, when you're on a hospice, it doesn't mean that you can't go to the hospital. I've worked with patients who perhaps they have a UTI, they need an antibiotic, or perhaps they need a level of care that they're not able to receive at home, perhaps around pain management. That medication can only be dispersed in the hospital. Doesn't mean you can't go. It just means the intervention, the level of intervention at the hospital is going to be different. Most people, any good social worker would tell you, when you sign on for hospice, it's an ongoing conversation. You can revoke hospice at any point as a patient. You can also change kind of your limits of intervention, I would say. So you can say, I'm not really ready to declare that I want to do not resuscitate, but maybe 8 months down the line, that changes. So you very much are a partner in your care on hospice. It's not like someone's deciding those interventions for you.
Can I ask a follow-up?
Yeah.
So what I see is, and I'm seeing with him, and I want to apply it to myself, not necessarily because it's for Bob. I take our medication, okay? I've had some serious heart problems. If I'm lucky to live to, 85, 90, can I tell hospice, get me off of medication? Don't keep me, if beta blockers and all these things are helping me, can I say, no more?
Yes,
And just let me.
yes. If you are.
Let me be.
Yes. You can also, and I'm sure the medical aid and dying person will talk more about this, you can also declare that you no longer want to receive food. Or that you no longer want to receive any sort of fluids or liquids. That varies, that's an ongoing conversation that you're discerning with your people, your medical team, and that might change over time. I've had people who start off on hospice. I work very closely with Johns Hopkins, and all of a sudden they were approved for a clinical trial. If you are on hospice, you can't be in a clinical trial because really hospice means no life-saving interventions. So no Hail Marys, no, I'm gonna just try this. Hospice is really about managing pain and comfort at the end of your life, recognizing the curative aspect of your journey is done. Yeah.
Rev Amy, my Aunt Mary passed away, and this is where my question comes from. I was talking to one of her nurses at the end of her life, and I discovered to my horror that something called a dry death, when you don't get fluids, is an easier death for the body physically. Are people educated, like the family or the patient, the person, how to approach the physical death? Like, is it good to not?
Yeah, sure. So the question was, in this case, like a dry death, meaning someone choosing not to receive fluids, and is that possible? And are people educated by a hospice around that type of death? I think so, if the hospice is really doing their job. And this is where my end of life death doula training comes in. A lot of times you may have heard Cheyne-Stokes breathing, or what happens at the end of life for some people if they have an abundance of fluid, which is a kind of gasping of air. There are ways to medicate that, but it's kind of uncomfortable for the people, not the patient. It's not painful. It's not like the person is feeling what's happening, but it's hard to sit and listen to that. So sometimes people will have, they'll have fluids removed, or they'll withdraw any sort of like water fluids to eliminate or suppress the secretions at that point.
So the family is advised and helped.
The family, yes. And I will say, I mean, you can't do a lot of research on this, but the body does this remarkable thing as we die, which is the body takes over and it shuts down. And it's actually, I'm sure you can relate to this, having been with people as they're dying. It's a very sacred process because people go internal. You know, hearing is the last sense to go, so people can still hear you, but often they close their eyes. They no longer are verbal. They maybe aren't responsive in the same ways that we think of someone being present. It doesn't mean they're not present, but it's a very internal, inward process. And that sometimes can be really hard for people to sit and be with, but it's one of the most sacred and beautiful experiences I think I've ever had. So I just want to kind of go over a few myths, and then I'm going to hand it back to Vicki, and we'll kind of go from there. So one of the myths is hospice means giving up hope. I don't think that's true, but I think that means you're living with realistic expectations. So you kind of have heard from your doctors, your medical team, this is not a curative, medically diagnosed condition. So the question then becomes, well, how do I live with it? And what does that mean for your needs around care, around pain, around access to how you want end of life to be? Talked about hospice as a place. I know in Denver, in the Denver region, we do have a few hospice houses. We have, I think, 7 different hospices in our region. Not all hospices are the same and not everyone's experience with hospice is the same. If you're in a skilled nursing facility, hospice can come to you. Hospice means that the myth is that hospice means that someone is actively dying or they're gonna die soon. That's not the case. As I said, people can live for years on hospice. You just have to get recertified every 6 months. So, it doesn't mean that you're terminal and gonna die within 6 months. It just means that trajectory is changing. Hospice is only for elderly or our elders. That is not true, as Vicki mentioned. Kids are on hospice. All ages of folks are on hospice. Children's Hospital has a great hospice unit here in Colorado. So hospice can apply at any age and time in life. I don't know where this myth came from, but someone asked me recently, is hospice only for cancer patients? No, anybody with a terminal condition can receive hospice care. That can include everything from COPD to heart failure, lung failure, kidney failure, all of that. This is a really popular myth, I think, that hospice means that individuals have to give up their own doctors or medical team. That's not true. You actually expand your team when you're on hospice, meaning you get a hospice doctor, you get a social worker, you get a CNA, you get a chaplain, you get a whole range of services that are unlocked when you access hospice care. Hospice provides 24-hour care. That is a myth. And I think this is really important because some of the people that I've known to have what I would say not a great experience with hospice kind of go into it with the expectation of once you declare that you want to receive hospice care, that those people, that nursing staff is going to be there 24/7. They're not. It's going to mean that you kind of have to become present in attending to your loved one's needs. Now, you can't administer medication. There will be an on-call 24/7 nurse that will be available to you to administer medication as needed. CNAs will come by on a regular basis for bathing, routine care, wound care, stuff like that. But the reality is, especially if someone is at home, people aren't going to be there 24/7. So it's a responsibility that you're taking on as a caregiver to be a part of their care in this way. I know that brings a lot of apprehension, a lot of fear, a lot of kind of, I think, uncomfortableness for family members. And I'm not a trained medical professional in that way, right? And I do think it's fair to ask of a hospice, especially in the end, I need more support here. So that might mean that you're stepping into your role as partner, spouse, daughter, friend, whatever. So there will be a conversation in the end about how maybe that care needs to be and will look different. Yeah.
Amy, I understand here in Colorado that physician assisted choice of death is legal.
That's right.
Is that part of hospice care?
It is. It's a different conversation, and I think it's.
You don't have to go in, I'm just.
No, I think some hospices, the caveat being, some hospices are more comfortable with that than others based on the which hospital system they're a part of. There are also ways, end of life doulas, a whole network of people who are also supportive of people, accompanying people in death, and that hospices have access to. So not every hospice is going to advocate or reveal that resource to you. I want to just finish with this, that hospice means kind of giving up control. And in my experience, both personally and professionally, I think hospice again gives us more choices, gives us more options. Gives us the opportunity to say, one of the most beautiful deaths I ever was a part of was someone who wanted to go to the beach and see the ocean for one last time. So the hospice team was able to transport someone, roll them down to the water, and they put ocean on his toes. And like, what a beautiful thing. So you can't do that if you were in a hospital. So hospice in my mind gives you more choices. It's really about you honoring for yourself and the people around you, what this transition can be. And, I'm a big fan.
Go ahead.
What about the situation where medical power of attorney is in control, whether it's a mental issue or?
Repeat the question, please.
Yeah, so the question was, what about where medical power of attorney is involved? There's financial power of attorney, medical power of attorney, and a healthcare advocate, right? All of those can be designated. And when you sign up for hospice, the intake process is about 2 to 3 hours because they go over all of this. They will ask you, who do you want to make these decisions for you if you cannot make them for yourself? But if you are there are some safety measures in place, I guess I should say. So if you are the one that's empowered to make the medical decisions for someone, you can't decide that they need hospice. Again, that's a doctor's decision. There's a form 2 physicians have to sign to declare someone to be hospice eligible. At the same time, that unlocks these services. So a social worker would begin to be involved. And so if there was an issue, for example, around care or access to care, you would have more eyes on that person than just that one medical power of attorney, which personally I think is a good thing. Yeah.
I've known people that have been on hospice and have gone off it. What criteria is involved in that?
You can self-select to go off hospice, or if your disease changes to the point where you no longer meet the hospice eligible criteria. There are criteria involved, and you can find that out online.
Does that mean you're curative? You go off?
No, it maybe just means you wanna access a clinical trial, or you revoke hospice and say, you know what, I do want to go to the hospital. I want to continue to receive chemo, or I want to continue to have this surgery, even though, surgery, for example, would not be approved for a hospice patient. So it's really the patient's choice, or if you no longer meet the hospice criteria at that point.
Or your medical power of attorney choice?
Or your medical power of attorney, yeah.
Are there times when their hospice teams are all busy and they're not available? How?
Yeah, hospice teams are really stretched thin. Vicki can attest to this. This is why most hospices rely heavily on volunteers, not for the medical part, but for the accompanying part. Hospices often will negotiate respite care for caregivers, for example, or they will have someone, the hospices that I've been a part of and worked with really share a belief that no one dies alone unless they want to. So often they will send people out to just sit with the family, or a volunteer that maybe will run errands for the family so that the family can be present. But yeah, do you want to say any more?
Well, we're working to create a group or a team that could fill in, that can also be there, but only as a volunteer type person. So if you were wanting hospice and there was a shortage and you needed that emotional, spiritual type support, that's what we're kind of working on getting going. I mean, you do need to, here at St. Andrew, yeah, you do need to have the medical team, you need the team. You need the 5-member team, you know, to be on hospice, because then you have to have the certification, they have to approve you to be able to be on it. But as far as the other part of it, the emotional and spiritual support, we're working to try to get that going so that we can be a part of that. Does that answer your question?
I guess it is, and I suppose you would go on a wait list if you were.
Well, I think doctors will, a doctor typically will say, you know, have you thought about hospice? Have you considered hospice? And then they would be the ones that would give you.
Are you asking though, like during the dying process, what happens
Well,
if
if
a hospice
somebody
is
needs
busy?
hospice,
Um,
and all those 5-people teams aren't available, do you go on a wait list for it, or?
no, the hospices are regulated by the Joint Commission. So there is a medical kind of directive that hospices adhere to and are regulated, and you have to be recertified every 5 to 7 years as a hospice. And you have to meet all these clinical criteria. And one of the things they measure is the rate of response. So hospices, their Medicare funding reimbursement, all of that is tied to their ability to meet patient need. I will say that sometimes in my personal experience, families' anxiety increases as the time of death grows near. And so there's this kind of anxiousness around, okay, something's changing. I don't know what to do. I'm not a medical professional. I pick up the phone and I want somebody to be here now. That's not the way hospice works. It's not on demand. It may be a couple of hours before a nurse or a CNA could get there. I find that that's true most often at the very end when it comes down to medication. So hospices will deliver, in the case of like you're at home, will deliver medication to your home for pain management, but you are not allowed to disperse that medication. They kind of proactively have it there. So when there's a need, they can, whatever nurse is in the area can come by and administer the medication. So sometimes there is that window of tolerance of, okay, this is changing. I don't know what to do. And it can feel very helpless. And that's when your social worker, your chaplain, other people can also help manage that, volunteers, until a nurse or other person can get there.
Well, that's if you're on hospice, but let's say that your loved one has been given a diagnosis that hospice would be the best thing, but there aren't teams available.
Well, that's where a conversation with your primary care, that's where the conversation
They
starts.
can find them somewhere.
Yes,
Yes.
depending on your insurance, Medicare will, approve you for hospice care, and then you have a choice, whether that's Porter, Lutheran, or Denver. It's often based on geographical location, and it's also, I find, kind of based on experience.
Yeah.
So word of mouth, like what that's been like for you. There are certain hospitals, if you go to certain hospitals, they use certain hospices, but you have a lot of choice in that too. So the real tipping point, I guess, is that conversation with the primary care doctor or the care team of that person to say, you know, are we at this place? And again, that's not yours to determine. They're going to medically determine, does this person meet that criteria?
What's the time frame once you reach that point to the point where you're on hospice? I mean, does it take, the process take days, weeks?
No, sometimes it can even be in a day, depending on the situation where the person is. That's different if you're in a hospital versus like you're at home and perhaps you're not seeing your person, your medical provider on a regular basis. But usually that can be done, intake can be done within 24 hours. Okay, I see a lot of questions. Yeah.
We've had 6 people in our family on hospice. And we've never had a problem getting into hospice. It's been different states, different cities, and we have always been very impressed with hospice. Every team we've ever been a part of, it's been excellent. And then I just want to mention, this is a book that I just recently read called Being Mortal. Have you read it? It's amazing. It's written by a doctor. He's a surgeon. And he did not know how to talk to patients about dying. And he followed the nurses around to teach him how to learn to talk to people about dying. And he watched his father die. And he watched the hospice nurses and learned from them about how to teach someone about dying. I would recommend this book to everyone right now, because he talks to them, to us, about what are the most important questions to ask ourselves now. His name is Atul Gawanda. He's Indian, and it's fabulous.
And it's called Being Mortal.
Being Mortal.
Okay, okay, great. Anybody else? Let me go back here. Karen?
I wanted to say just one quick thing. My dad is in assisted living. And my brother's in Kentucky and he's a physician. And I'm out here in Denver, and we remotely manage his care through hospice. It's amazing. I go and visit every 4 months. My brother, who's still practicing, goes opposite when I go. And the hospice team calls me twice a week with an update on their dad. Sometimes they're visiting, and this is the hospice nurse. And he has the team of 5 and all of that. When I was there, the nursing staff at the assisted living facility said, "Have you ever thought of hospice?" And that day, we went through the intake process. They got the approval the next day with the second physician. And I'm like, oh, my life was in a whirlwind. Within 24 hours, my dad was in hospice. And Bob had mentioned he had a really bad hospital stay with over medication and all that. So he's been that, and I agree with you, hospice and their caretaking and medication, so on and so forth. That was last November. He just had his 94th birthday at the end of August. He's still in hospice. I think he is 94, so he's not the dad that I remember, so declining, but they have made it, but they're gracious. They're very gracious.
Yeah, I'd have to go off of that. Well, we were there with it when it gonna happen. And I can't believe that hospice got them with it through. If you would have seen the situation, you would not believe it now compared to.
And we totally think it was
was
because of hospice.
It was
That's
great.
neat.
It's 11:21. I want to just give our Zoomers a chance to ask a question or make a comment if they want to, so they don't feel they're interrupting our in-room conversation. Does anybody on Zoom want to make a comment? Susan, go ahead.
I have a question. My dad had said that the dry death is actually a very bad way to go, that it's very painful. Is that also a myth?
I think that's really kind of up to the person. I've known people to voluntarily say that they don't no longer want to receive fluids. I think it depends on whatever condition you're in the hospice for, because sometimes more fluid secretion can lead to more coughing, which actually slows down the dying process. So it just depends on the condition and the person, I'd say.
Okay. Can I do a quick question here to religious? Do people in hospice talk to either one of you about their religious thoughts, their beliefs? Do you talk to them about the afterlife? What's been your experience?
I was gonna share a couple of experiences that I have had. One of them, a gentleman and I were talking, and he said, you know, what is this that I'm doing? I mean, he knew the name of it. He knew it was hospice, But he goes, what am I doing?
You mean the
know,
dying
the
process?
dying process, you know, the fact that he had decided to be on hospice and not, do any, extreme measures, you know, he was not taking any of his medications anymore that were keeping him alive. So anyway, I said, well, you know, it's kind of a journey. You're kind of on a journey, you know, you're ending your life. You've decided that, they've told you there's nothing more that they can do for you. So you're just kind of on a journey. And, it was interesting because it was kind of like the light came on. And it was like, yeah, you're right, you know, and I feel like he just didn't know quite how to deal with it inside, you know, and it is a journey, you know, it's an emotional journey, it's a physical journey. But it can be a very peaceful journey too, you know, so, yeah. So, did you have a question?
Well, I just was unclear who is responsible for the medications. Is it your normal treating doctors? Or does hospice take over the control for medicine?
It's hospice.
Yeah.
Yeah,
So your treating doctor then keeps,
they receive like a report.
yeah, but we used to back out and let the hospice doctor do all the medicine.
Yeah.
My experience was that I, as just somebody off the streets with no medical training, was responsible for the administering the drugs to my best friend.
I think that really depends on the state, the situation in the hospice,
Yep.
and people's comfort level with that.
Yeah.
To your point, Steve, I've had people say, well, either in administering or agreeing to administer the medication or to even have someone be on hospice, am I killing them? And my answer is always no. You're supporting them. The body takes over at that point. There are legal limits to how much morphine you can give someone. And Colorado being a state that supports medical aid in dying, it's different than in Maryland and certainly the South and places like Texas and places in the Northeast and Northwest. It varies by state and it really varies by hospice.
Well, I felt reasonably comfortable doing that because Scotty and I had talked a great deal about, she did not want any pain. And she didn't care whether that ended her life earlier or not. She didn't want any pain. So I used that as.
That was your guide.
Yeah.
Right.
Yeah. And that's why these conversations are so important now to have.
But I thought at the time, you know, what do I know about drugs?
Yeah.
Zero.
Yeah, I do also think the spiritual needs of the dying are taken very seriously in hospice. I was part of an interfaith chaplain group. So we had priests that were available for last rites. We had imam who would go and be with Muslims as they die. We had a Jewish chaplain who, you know, they, in the traditional Jewish customs, have to be buried within 24 hours. So, you know, that person was a real advocate in connecting them with mortuaries and making sure that burial happened within 24 hours. So I find in my experience that there's been a personal respect for people at the end of life to attend to all the aspects and needs of care, spiritually, emotionally, physically, and socially. A lot of people on hospice still desire social connection. They desire touch. So we brought in therapy dogs. We brought in a herpist. We brought in a massage therapist. We brought in an acupuncturist. We brought in someone that did aromatherapy and Reiki. So it just unlocks a lot of services. Yeah.
I have a question about finances. Can you like overstay your welcome financially? You know, is there any point where you can get kicked out because you can't pay? I assume, you know, Medicare and then Medicaid is what happens. What about the finance side?
Yeah, it's not like there's a limit a financial limit in terms of, you know, you max out of your limit on hospice. You can be recertified as many times as necessary, and that recertification happens every 6 months. And, that is a benefit of Medicare, so you are Medicaid too, so you don't like max out your benefits.
Yeah, I wouldn't want my loved one, you know, to have the responsibility. for paying a bill.
over.
Yeah.
Yeah.
My daughter worked for visiting nurses, in the, she was a social worker in the hospice. And it's a team of like 9 people. She had like, now this is New York, so she had North Brooklyn. And you work like 5 people and there's always a chaplain within your group. She was really good friends with them, but everybody doesn't go there the same day. Right. And also she said she had to kick people off of hospice because, yeah, if they're out shopping, you know, you're not gonna be. She did, she goes, well, Mrs. So-and-so, she was like out shopping and so, yeah, once she had that kick, and she did that, like the social worker. And yeah, and then she had like a lot of funny stories though about some of the people with
You know, one of the things that I would really like to leave you with is, it's something that you shouldn't wait on. Don't wait until, you're in a crisis mode. If it's yourself or your loved one, if a doctor says to you, you might consider hospice, then they're pretty much letting you know that, you're kind of in that place where, you know, we've run out of all resources, you know, I mean, at this point. And if you trust your doctor, I'd look into it. Let the hospice people come in, do an evaluation, and they'll let you know if you're ready, you know, and, I've just heard too many times of people waiting too late. And then it's not a pretty situation, you know, I mean, things kind of can get out of control and it's, you want it to be peaceful and waiting too long is not a good idea. So if the doctor, and I will tell you, and one experience that I had was the doctor came in and said, you know, have you considered hospice? And the comment was, we'll think about it. Well, very next day, something went wrong physically with this person. And so the next thing you know, they're doing a blood transfusion on this person. And I was there visiting and could tell by the sound of the body, the person, it's over, you know, it's almost over. And so I thought, you know, because they hadn't decided to go on to hospice already, they were doing a blood transfusion and within 24 hours, she was gone. And so, you know, they just continue to do things because that's the way they are. That's what doctors do, you know, I mean, that's there to help life. So don't be afraid to be ready, you know, if a doctor recommends it, it's time, so.
We are out of time. It's 11:30. I'm sorry. I wish we could take more time, but talk to Amy and Vicky afterwards. Thank you, everybody. Amy, would you close us in a brief prayer? Thank you so much.
Let us pray. Holy and loving God, for this gift of life, we give you thanks, recognizing that this is indeed a journey and that you are closer to us than our very breath, so that in our living and our dying, there is nothing that separates us from you. And our conversations remind us of your loving presence, remind us that we are a community that cares, and help us to show up for one another when there is a need. Amen.
Thank you.
Thank you. Bye.
I'm not good. Yeah.